নমস্কার, আবার আমরা আমাদের ইনস্টিটিউট থেকে চলে এসেছি। আমি আমার একটা ছাত্রের অনুরোধে আমি একটু প্রোটন পাম্প ইনহিবিটর সম্পর্কে আমরা কিন্তু একটা ডিটেলস ভিডিও করছি। তো বেসিক্যালি প্রোটন পাম্প ইনহিবিটর একটা মোস্ট কমনলি ইউজড ড্রাগ অ্যান্ড widely prescribed drug all over the world, because proton pump inhibitor is the very novel invention in the drug history, because before the invention of the drug history, lots of drugs were there to suppress your acidity, but proton pump inhibitor is a peculiar type of agent which can control over the issue of the acidity. So that's why proton pump inhibitor is a very novel in- invention in the history of the drug or in the history of the pharmacology. But proton pump inhibitor was once upon a time very costly agent. But now lots of improvement has been taken place, and now the agent is very cheaper and within the reach of the commonplace people. So that's why proton pump inhibitor is no longer a very costly drug. It's a very cheap drug nowadays. But proton pump inhibitor is a very potent drug to suppress your hyperacidity. So today's topic is proton pump inhibitor. So proton pump inhibitor is also known as PPI. P for proton, P for pump, and I for inhibitor. So what is PPI? PPI is a very short term of proton pump inhibitor. Now look at the term proton. Proton equivalent to hydrogen ion. Proton equivalent to hydrogen ion. That means there is a pump which are releasing continuously the hydrogen ion. That means there is a pump. Suppose this is the pump. Suppose this is the pump. And through this pump, the hydrogen ion are being released. This is hydrogen ion are being released. So there is a pump through this hydrogen ion are being released, and this pump is called hydrogen ion pump or simply proton pump. So the pump which are continuously releasing hydrogen ion or proton, that is called proton pump simply. And why it is called pump? Because pump is a machine which is energy dependent. So why it is called the pump? Because this machine is regulated by the energy. If any machine is regulated by the energy and pushing out or pushing in something, any machine which is regulated by the body energy and pushing out or pushing in something towards their concentration gradient, that is called pump. So what is pump? Now pump is a energy dependent machine. Pump is a energy dependent. And what is the form of energy within our body? What is the form of energy within our body? that is ATP, adenosine triphosphate. So pump is a pump is an energy dependent machine which are pushing out or pushing in, which are pushing out or pushing in against their concentration gradient. So this pushing out or pushing in against their concentration gradient, against the concentration gradient. Means suppose this is a bucket and this bucket contains salt water. Suppose this is the water and this is the salt. This is the salt. Suppose in this salt water, the concentration of salt is higher, much more higher. The concentration of the salt into the solution is much more higher. Now, if I connect a pipe here and through this pipe I am pushing more salt into this solution. So through this pipe I am pushing more salt into this solution. So through this pipe I am pushing more salt into this solution. So this will be not an easier task because already salt concentration here is more. So when salt concentration here in the solution is more, that means partial pressure of the salt within this solution will be more. That means partial pressure of this salt within this solution is more. Still I am pushing more salt into this solution, overcoming this already raised partial pressure, overcoming already raised partial pressure of the salt into the solution. So when I am pushing more salt, I have to give extra energy. I have to give extra energy. So when I am giving extra energy to push something within any solution or outside of the solution, that is totally energy dependent, and that energy dependent machine is called pump. That energy dependent machine is called pump. So what is pump? Pump is energy dependent machine which is pushing outward or inward anything against their concentration gradient. So that is energy dependent channel. Any energy dependent channel which are working against the concentration gradient of a specific substances, that is called pump. So proton pump, that means proton channel. Inhibitor means it inhibits, means it closes. So the drug which are closing the proton pump, that is called proton pump inhibitor. So what is PPI? The PPI are those class of drugs, those group of drugs which are closing The proton pump is called proton pump inhibitor. So proton pump inhibitor basically is a group of drugs which are basically suffixed with, which are basically suffixed with prazole, with prazole, like omeprazole, like esomeprazole, like pantoprazole, like ribiprazole, like your lansoprazole, and your tenacoprazole. Your tenacoprazole. So, what is proton pump inhibitor? A proton pump inhibitor are a group of drugs. They are suffixed with prazole, and they mainly inhibit the energy dependent hydrogen ion pump to suppress the over secretion of the hydrogen ion to produce the hyperacidity. So proton pump inhibitor is a group of drugs, group of drugs which inhibit the proton pump, and thus they inhibit or closes the proton pump, thus hydrogen ion efflux will be reduced. That means hydrogen ion pumping, efflux means pumping, will be reduced, and formation of hydrochloric acid, concentration of the hydrochloric acid, concentration of hydrochloric acid, or formation of the hydrochloric acid will be reduced, and suppresses the hyperacid. Hyperacid. So these classes of drugs are called proton pump inhibitors. Now, exactly where this proton pump is located? Look, where this proton pump is located? Proton pump is located in lots of places, but in this context, I will restrict my discussion to the stomach. So in the stomach, there are lots of cells. There are lots of cells and those cells are called parietal cell. Those cells are called parietal cell. So in the parietal cell, this surface, this surface is called luminal surface of the parietal cell. Why it is called the luminal surface? Now because this is called the lumen of the stomach. So this surface or this face, these faces are directed towards the lumen of the stomach. So these faces are called lu- luminal surfaces of the parietal cell. So these faces are called luminal surfaces of the parietal cell. So this is the luminal faces of the parietal cell. So in the luminal faces, there is a particular channel. There is a particular channel. Just I am giving the functional diagram. So these particular channels are called canaliculi. Actually, canaliculi is small passage. Canaliculi is the small passage. So these passages are called luminal canaliculi of parietal cell. Luminal canaliculi of parietal cell. So these are called luminal canaliculi of parietal cell. So in the luminal canaliculi, there are lots of pumps are there. There are lots of pumps. These are the pumps. These are the pumps. So these are the pumps. These are the pumps. I am redrawing one parietal cell in a larger diagram. I am redrawing one parietal cell in a larger diagram. That means I am just magnifying this parietal cell. Suppose this is the parietal cell. This is the parietal cell, and this is the canaliculi of the parietal cell, and this is the luminal surface of the parietal cell. Just compare. This is the parietal cell. This is the luminal surface of the parietal cell, and this is the canaliculi of the parietal cell. Clear? Within this, within the border or along the border of this canaliculi, along the border of the canaliculi, there are the pump. There are lots of pump. There are lots of pump. There are lots of pump. Yes. And this pump pumps out hydrogen ion. This pump pumps out hydrogen ion. This pump pumps out hydrogen ion. That means these pumps pump out hydrogen ion into the lumen of the stomach. Into the lumen of the stomach. They are pumping out hydrogen ion into the lumen of the stomach. into the lumen of the stomach. Exactly, this pump is a protein substance. Protein substance. Exactly, protein, transmembrane protein. Exactly, transmembrane protein. And this protein, suppose this is the pump, suppose this is the pump, and this pump basically composed of this pump basically composed of composed of alpha and beta subunit. This pump, suppose this is the pump, I am just enlarging the picture of one pump. Suppose this is the pump. This pump composed of alpha and beta subunit. Exactly two alpha unit and two beta unit. But exactly alpha unit made up of lots of lots of lots of cysteine. Lots of cysteine. What is cysteine? Now cysteine is a sulfur containing amino acid. What is cysteine? Cysteine is a sulfur containing amino acid. So this alpha unit is made up of lots of cysteine molecules or cysteine amino acids. You know, protein is made up of a linear or branched chain of amino acid. So these alpha units are made up of cysteine moieties as the principal amino acids. Exactly, when any PPI, actually when I am loading any PPI, any PPI into the blood, when I am loading any PPI into the blood, those PPI are coming via blood circulation into the stomach. Those PPI are coming into the stomach via blood circulation. And those PPI are easily going into the parietal cell. Those PPI are going into the parietal cell. So suppose here the PPI is coming. Here PPI is coming. Exactly, PPI is a weak alkaline substances. PPI is a weak base. You know, acid is always attracting the base. Acid is always attracting the base. So since PPI are weak bases, so they will be attracted by the acid into the stomach. They will be attracted by the acidic medium into the stomach. So within the parietal cell, the pH is less than 1. pH is less than equal to 1. So very strong acidic medium. Very strong acidic medium. So this very strong acidic medium attracts the PPI within the parietal cell. Now PPI has two subunits. One is pyridine subunit. One is pyridine subunit. And another one is another one is benzoimidazole subunit. Another one is benzoimidazole subunit. So PPI has two subunits in their structure. One is pyridine subunit or pyridine moiety. Another one is benzoimidazole moiety. And these two subunits are connected by methyl sulfonyl bond. Are connected by methyl sulfonyl bond. So if you study the structure of any PPI available into our market, basically they are made up of two moieties. One is pyridine unit, another one is benzoimidazole unit. And this benzoimidazole unit basically connected with the pyridine subunit by methyl sulfonyl bond. As for example, rabiprazole, pantoprazole, esomeprazole, omeprazole, lansoprazole, they all have the pyridine subunit and benzoimidazole subunit. So once they are introduced into the body, they are reaching to the parietal cell via circulation. Once they reaching the parietal cell, they are entering into the parietal cell. After entering into the parietal cell, first, so this is the pyridine subunit and this is PPI. This is the pyridine subunit and this is the benzoimidazole subunit, and they are connected with methyl sulfonyl bond. So once entering within the cytosol of the parietal cell, they are attracted by the luminal they are attracted by the canali they are attracted towards the canalipuli. How they are attracted? The first, one hydrogen ion is connected with the pyridine moiety. One hydrogen ion is connected with the pyridine moiety. So when hydrogen ion will be connected with this pyridine moiety, the chain will be heavier. The total structure will be heavier. And when the structure will be heavier, they have lesser kinetic motion. Suppose I am my weight is very much more than the normal weight. My BMI is very high. So can I run faster? No, I can not run faster. I will walk slowly like an elephant. So when the hydrogen ion will be connected with this pyridine subunit, the total structure will be much more heavier than earlier. So the range of kinetic motion is lesser than before. So they are getting collected around, they are getting collected around this canal. They are getting collected around this canal. They are getting collected around this. Clear? So once PPI is introduced within the parietal cell cytosol, the hydrogen ion first gets tacked, gets attached with the pyridine subunit of the parietal cell. So when the total structure is attached with the hydrogen ion, they will be heavier. This heavier structure cannot move faster. So they are all connected around the canaliculus. Second step is there. After that, another hydrogen ion will be attached. Another hydrogen ion will be attached. This second subunit. What is the second subunit? That is benzoimidazole subunit. So first pyridine will be attached with hydrogen, and the second step, in the second step, the benzoimidazole subunit will also be tagged with the hydrogen ion. That means two moieties. There are two moieties. One is pyridine, one is benzoimidazole. So pyridine is attached with the hydrogen ion, and benzoimidazole also attached with the hydrogen ion. That means they are much more slower. They are much more slower. But when the second subunit is attached with the hydrogen ion, there are some conformation change, or there is some structural change within this PPI. There is some structural change within this PPI. And each structural change, basically, they are they are basically they are taking the form of sulfonamide. They are taking the form of sulfonamide form. Sulfonamide form. This sulfonamide form is the active form of PPI. This sulfonamide form is the active form of PPI. So I am recapitulating. Suppose I am suffering from the hyperacidity. I am going to the shopkeeper and I am requesting the shopkeeper to give me one pantoprazole. So I am swallowing the pantoprazole. Those pantoprazole are getting mixed within my blood and getting transported to my stomach. After getting transported to my stomach, they will be readily incorporated, they will be readily entering into the parietal cell, because this PPI is dormant form or not active form. Dormant means not active. So, if you want this PPI to function, first it should be activated. So where it should be activated? Now it will be activated within your parietal cell. What is the process of activation? Now first, the pyridine subunit will be tagged with the hydrogen ion, that is called first protonation reaction, and after that they will be accumulated around the canaliculus because of the lesser kinetic action, because heavier chain, heavier substance, lesser kinetic action. And after that, basically, the benzoimidazole group will be tagged with the another hydrogen. This is called second protonation reaction. And as soon as the hydrogen is attached with the second group, there will be some structural modification. And finally, it will be converted into the active form. This active form is the sulfonamide form. This active form is the sulfonamide form. Now it is ready for appropriate action. Now it is ready for appropriate action. Exactly after activation, this this activated molecule after activation, suppose this is the activation, now this is the activation, so these activated molecule are connected with the cysteine. That means this active molecule, this active PPI are connected with the cysteine. Look, initially when there is no connection with the cysteine, the alpha unit can open, and when the alpha unit can open, suppose just suppose initially, suppose this is the beta unit and this is the beta unit and this is the alpha unit and this is the alpha unit, and these alpha unit are connected are, are, are connected with the are made up of the different types of amino acid, and mainly cysteine is prominent here. Cysteine amino acids are prominent here, so these are the cysteine. These are the cysteine amino acids. Once PPI is activated, this activated PPI, exactly when there is no active PPI, the cysteine amino acids or the alpha units will be functional. That means they can open, so hydrogen ion can pass. Hydrogen ion can pump out. They can open, and hydrogen ion will be pumped out in the normal cases. But if you administer PPI and once PPI is activated, those activated PPI are getting connected with this cysteine amino acid. Actually, the cysteine amino acids, there are approximate 28 to 30 cysteine molecules, and some PPI are selectively connected with a group of cysteine amino acids. Some other PPI will also be selective in connection with the cysteine molecules. So every PPI will not attack the same cysteine molecules. The PPIs are different in attacking their different cysteine molecules, but overall they are attacking the cysteine molecules. And when they are attacking the cysteine molecules, they are inactivating this pump. When there is no such attack, the pump was active, and when the pump was active, this pump will be pumping out the hydrogen plus ion. This pump will be pumping out the hydrogen plus ion. This pump will be pumping out the hydrogen plus ion. But once the activated PPI is connected with the cysteine molecules. Once the activated PPI is connected with the cysteine molecules, normally this pump will be inactive. This pump will be inactive. And when the pump will be inactive, normally they cannot pump out the hydrogen ion. When the pump will be inactive or pump will be non-functional, the pump cannot function. And if pump cannot function, so no hydrogen ion will be coming into the lumen of the stomach. And if there is no hydrogen ion, there will be no question of the production of the HCl. There is no question of the production of the HCl. Another thing, exactly, this pump is energy dependent. This pump is energy dependent. Exactly, this pump, suppose this is the parietal cell, just generally look, this is the parietal cell and this is the pump. This is the pump. This is the pump. This is the pump. So this pump basically pumps out hydrogen ion from the parietal cell. This is the parietal cell. In the normal condition, this pump pumps out hydrogen ion from the parietal cell. So in every cycle, the hydrogen ion will be deficient within the cell. The amount of the hydrogen ion will be decreased within the cell. So when hydrogen ion is the positive ion. When the pump is pumping out lots of positive ion, that means the cell is getting much more negative. In every normal cell, the inner part is negative, the outer part is positive. That is true. But if you kick out more positive ion from the cell voltage will be going much more negative. Suppose in the normal case, the inner voltage is minus 90 millivolt in the normal case. But if I kick out much more positive ion from within the cell, the inner surface voltage will be much more lower than minus 90. Suppose after kicking out much more hydrogen ion or positive ion, now the voltage is coming down towards minus 120 millivolt. This phenomenon is called hyperpolarization. This phenomenon is called hyperpolarization. That means hyper negativity. Some cell cannot tolerate this hyper negativity. So cell has automatic mechanism to balance the positive and negative ion. So when lots of positive ion is going out, cell is trying to bring some positive ion back within the cell. Now cell is trying to bring some positive ion back within the cell, and this positive ion is now potassium. Look, in the normal situation, the parietal cell is producing hydrogen ion. There is a pump. This pump is continuously pumping the hydrogen ion. Suppose this is the cell and this is the pump. This pump is continuously pumping out the hydrogen ion outside. Now the inside is getting much more negative. To balance this negativity, now the cell is bringing some another positive ion inside. To balance this over negativity, now the cell is bringing some another positive ion inside. And this positive ion is potassium now. This positive ion is potassium now. You know, potassium is much more within the cell in normal cases. Potassium is much more within the cell. But here, look at the case. Potassium was there much more within the cell. Still, cell is bringing more potassium within the cell. That means this is a perfect example of the pump. And this pump is called hydrogen potassium pump, especially hydrogen pump. And since hydrogen is known as proton, so this pump is also known as proton pump. So these are all proton pumps. These are all proton pumps. And since it is a pump, so it is regulated by the energy. How it is regulated? Now ATP is bringing the energy in form of the phosphate, and these phosphate are supplying the energy. So ATP will be breaking down. ATP will be broken down. ATP will be broken into. ATP will be first. ATP will be broken into ADP plus one inorganic phosphate, and this phosphate is giving the energy to this pump. And this breakdown is performed by a particular enzyme that is known as hydrogen potassium ATPase. That is known as hydrogen potassium ATPase. So the connection of the active PPI, with these cysteine molecules not only inactivates this pump biochemically and anatomically, but also inactivates this enzyme. তাহলে this active PPI proton pump inhibitor, when connected with the cysteine amino acids of the alpha unit of the pump, proton pump, they not only shut down this pump, but also inactivates this hydrogen potassium ATPase enzyme. So if this enzyme is blocked, ATP will not be broken down into phosphate. So if there is no phosphate, there will be no energy. So the pump will not function. So there are two mechanisms. One is anatomically blocking this pump. Sorry. And another one is enzyme is inhibited, so pump is not functional. And when the pump is not functional, normally hydrochloric acid will not be produced. So I repeat, just imagine. Suppose this is the inactive proton pump inhibitor. These inactive proton pump inhibitor are being activated. Now this is the active proton pump inhibitor. This active proton pump inhibitor, suppose there is a cysteine molecule of the pump. This active proton pump inhibitor are connected with the cysteine molecule of the pump. And when they are connected with the cysteine molecule of the pump, normally the pump is closed. This is one mechanism. So when the pump is closed, normally hydrogen ion will not be going out. That is one mechanism. So this is the inactive PPI. The PPI within the parietal cell getting active. Now this is the active PPI. And this is the pump. This active PPI is getting connected with the cysteine molecule of the pump, and when the active PPI is connected with the cysteine molecule of the pump, normally the pump will be closed. One mechanism. Second mechanism, suppose this is the active PPI. This active PPI, suppose this is the ATPase enzyme. Which ATPase? Hydrogen and potassium ATPase. So this active PPI are going to the ATPase enzyme and damages this ATPase enzyme. And when this ATPase enzyme will be damaged, so there will be no question of producing phosphate from the ATP. And when there will be no question of the production of the phosphate from the ATP, normally the pump will not be functioning. The pump will not be functioning. And when the pump will not be functioning, normally the hydrogen ion will not be producing. And when there will be no production of the hydrogen ion, there will be no production of the hydrochloric acid. Now, basically, there are lots of PPI I already told. That is pantoprazole, esomeprazole, omeprazole, lansoprazole, and um, and and rabiprazole, etc. But there is some chemical modification of the pyridine group or benzoimidazole group. So a newer PPI has been introduced, that is known as tenetoprazole. Now, what is the special thing about the tenetoprazole? What is the special thing about the tenetoprazole? Tenetoprazole basically, tenetoprazole basically contains another group. That group is known as imidazopyridine. Imidazopyridine. তাহলে the newly discovered PPI is known as tenetoprazole. In the tenetoprazole, pyridine molecule is there, and in place of benzoimidazole, there is imidazopyridine. In place of benzoimidazole, there is imidazopyridine. Now, what is the advantage or what is the benefit of incorporating imidazopyridine in place of benzoimidazole? Because all other PPI contains pyridine and benzoimidazole. But in tenetoprazole, the benzoimidazole will be replaced by imidazopyridine. What is the special thing about? Now, basically, this imidazopyridine, when attached with the second hydrogen ion, that means second protonation reaction, normally they will be irreversibly collected and inactivates this pump. That means I am saying that this imidazopyridine ring, this is the ring or a ring shape, This imidazopyridine ring helps pantoprazole is very much longest acting. That means the action of duration or half life is much more longer. The half life is much more longer, and the duration of action is much more longer, and better control of acidity. Because suppose this is the graph, this is the concentration of ppm, and this is the time. Now, if we look at the graph of pantoprazole action, the graph is like this. That means the action, division of action is much more, and the area under this curve is much more bigger. The area under this curve is called action of the PPI. The area under the curve of the graph of the concentration of PPI versus time. Concentration of PPI versus time, the area under the curve represents the duration of action, or duration of action of PPI. So you look the area under the curve. All other PPIs are like this. So area under the curve of the all other PPI is smaller. But area under the curve of the tenatoprazole is much more larger. When the area under the curve is larger, that means the duration of action, the half-life is much more larger of the tenatoprazole because of the presence of the imidazopyridine ring in place of benzoimidazole ring. So this is the longest duration action of PPI. Pantoprazole is given both in oral formulation and IV formulation. Rabiprazole is much more better than lansoprazole. So they are very much good PPI. Now this parietal cell has lots of stimulating factor to produce HCl. The most important stimulating factor is acetylcholine. The most important stimulating factor is acetylcholine, because the mu receptor is there, muscarinic receptor, and when acetylcholine is coupled with this muscarinic receptor, normally the parietal cell will secrete hydrogen ion. So if we block this acetylcholine receptor, theoretically the acid will be suppressed, but acetylcholine receptor blocker or anti-muscarinic agent like acts like the atropine. That means in the parietal cell, lots of stimulating factors are there. One of those stimulating factors is acetylcholine. So if we block the acetylcholine with atropine, the HCl production will be reduced. But it is not comfortable for the clinician because atropine has lots of side effects. So that's why we normally don't do that. Second thing, there are another receptor, that is H2 receptor. And this H2 receptor accepts histamine, accepts histamine. And when histamine is connected with the H2 receptor, this parietal cell will produce lots of hydrochloric acid. So suppose this is the parietal cell, this is the parietal cell, and there are histamine receptors. And when the histamine is connected with this receptor, this parietal cell is releasing lots of hydrochloric acid. So I have to block this histamine receptor or H2 receptor. So if I block this H2 receptor, if I block this H2 receptor, normally there will be suppression of the HCl production. But it is not very long time. It is not for very long time, because other activating factors are there. One of the another important activating factors is gastrin. So gastrin is a basically neurohormone, or gastrin, not neurohormone. Gastrin is a basically hormone, actually GI hormone, and they are basically secreted from the G cell or gastrin secreting cell into the antrum of the stomach, into the pancreas, into the duodenum, etc. They mainly secretes the gastrin, and this gastrin helps parietal cell to produce lots of hydrochloric acid. Suppose this is the gastrin, this is the gastrin. They are connecting with the G receptor of the parietal cell, and when they are connecting with the G receptor of the parietal cell are releasing lots of hydrochloric acid. So if you want to block each receptor, you cannot block all these three receptors. So if you want to block any one of these three receptors, look here. Suppose this is the parietal cell, and these parietal cells are secreting hydrogen ion. So number one is acetylcholine, number two is histamine, number three is gastrin. So all these three I cannot block at the same time. All these three I cannot block at the same time. If I block histamine, two other factors stimulating this parietal cell to release hydrogen ion. If I block acetylcholine, then two other factors are stimulating parietal cell to release hydrogen ion. So I cannot block all these three conditions. So better I am blocking this opening, this pump. If I block this pump, any condition can come to this cell, but nothing will come out. Any condition can come, acetylcholine can come, histamine can come, gastrin can come, but I'm blocking this opening. And when I'm blocking this pump, so nothing will be coming out. Clear? So that's why proton pump inhibitor is much more potent than any other inhibiting drugs. Okay. Now, regarding the side effects of the proton pump inhibitor. Look, any drug, if we take for a prolonged period, any drug, if we take for a prolonged period, there are two problems. One is side effect, another one is my body is accustomed to this drug. That is called tachyphylaxis. So my body is accustomed to this drug molecule. So normally you have to change that drug. So side effect. PPI. Look here. This is the stomach. So I am applying, sorry, a minute. So I am applying the PPI, and PPI blocks the AC. So when ACL is blocked, the intragastric pH will be raised, will be rising or coming down. The in Listen carefully. If I block ACL within the stomach, the gastric pH will be rising or coming down. The gastric pH will be rising. The gastric pH will be rising. That means the inner surface of the stomach will be more alkaline. The inner surface of the stomach will be towards alkaline. In this alkaline atmosphere, or in this basic atmosphere, lots of bacteria will be growing. Lots of bacteria will be growing. Because in the acidic medium, the bacteria will be killed down. In the acidic medium, the bacteria will be killed down. But if we neutralize the acid, or if we make the atmosphere more alkaline, there will be no acid. So bacteria will not be killed. Rather, they will be growing out in the exponential form. And those bacteria will be coming upward, backward, and coming into the lung. And they can produce the pneumonia. Via aspiration. So this is the first side effect. Prolonged use of PPI can produce pneumonia in the long term, because the inner gastric atmosphere is very important for prevention of the acid reflux, because this is the esophagus. This is the stomach, and this junction is called gastroesophageal junction. This junction is called gastroesophageal junction, and within this gastroesophageal junction, there are concentric circular muscle. And these concentric circular muscle, look here. Suppose this is the esophagus, this is the stomach, and this junction is called gastroesophageal junction. And within this gastroesophageal junction, there is concentric circular muscle, and this concentric circular muscle acts like the valve. This concentric circular muscle acts like the valve. So the acidic food cannot backflow, because when there is the acidic atmosphere, this valve is active, and acidic food cannot backflow into the esophagus. But when you are making the atmosphere more alkaline, then the valve is not so much active. So the gastric content will be backflowing, and within the gastric content there are lots of bacteria, because there is no acid. There are lots of bacteria, and those bacteria are coming into the lung, and they are producing aspiration pneumonia. That is first side effect. Second side effect is that suppose in this alkaline atmosphere, after prolonged use of the PPI, proton pump inhibitor, there is lesser amount of HCl. So HCl production is blocked. So the inner atmosphere is more alkaline, and in this more alkaline atmosphere, calcium carbonate cannot be absorbed because calcium carbonate is more basic. So they will be dissociated in the acidic medium. So calcium carbonate is basic substance. They will be dissociated, they will be broken down into the acidic medium. And when there is no acidic medium, this calcium carbonate will not be broken down. And when the calcium carbonate will not be broken down, so calcium will not be dissociated from the carbonate and calcium absorption will be less. So calcium absorption will be less. And when there is lesser absorption of the calcium, it can lead to the hypocalcemia. Hypocalcemia. That means the amount of the calcium into the blood will be going down. You know, when the amount of the calcium into the blood will be going down, this is a very serious condition. So, to balance this serious condition, your bone, suppose this is your blood vessel and this is your bone. Suppose when calcium concentration into the blood will be more low, that condition is called hypocalcemia. So to counterbalance, to balance this condition, emergency condition, your bone will release more calcium into the blood. Your bone will donate more calcium into the blood to reverse back this imbalance. That means suppose this is my blood, if my blood has lesser calcium, that is very emergency situation. So my bone is giving or throwing calcium into the blood so that the calcium amount of the blood will be higher. So this compensation mechanism produces lots of pore into the bone. Due to lesser calcium absorption in the long term, due to long-term use of the proton pump inhibitor, your blood calcium concentration will be getting lower and lower. But this is a very emergency situation of the hypocalcemia. To maintain the balance, now your bone is active and bone is throwing some calcium out into the blood. Bone is throwing. So now there will be lots of pore within your bone, and that is called osteoporosis. And this leads to the fracture. So prolonged use of the PPI in the long term, they can make your bone fracture. So bone fracture. Now, apart from calcium, there will be lesser absorption of the magnesium. That means hypomagnesemia. And lesser amount of the iron absorption also. So anemia will be there. Now there is a very interesting thing regarding the anemia. Look, whatever iron into the food, into the diet we get, it will be in the ferric form. Whatever iron I am eating through my food, through my diet, through my food stuff, it will be in ferric form. But during absorption, ferric will not be sufficient. During absorption, the ferric should be oxidized. The ferric should be oxidized into the ferrous form. Sorry. Ferric will be reduced into the ferrous form. Ferric will be reduced into the ferrous form. So, reduction. Ferric, there are deficiency of the 3 electron. There are deficiency of the 3 electron. Now there is deficiency of the only 2 electrons. So that's a 2 plus. So 1 electron will be attached here. That means reduction. So what is the definition of the reduction? Either addition of the hydrogen or addition of the electron. Either addition of the hydrogen or addition of the electron. Now the ferric form will be reduced into the ferrous form for proper absorption. In that case, you have to add the hydrogen ion. And from where this hydrogen is coming, it will be coming from your HCl. So if there be no HCl, there will be no hydrogen ion and no scope of the reduction of the ferric into ferrous. So your iron will not be absorbed. And when there will be no absorption of the iron, it will lead to the anemia. Look here. Suppose I am taking the mutton liver. Mutton liver is a rich source of iron. But in the mutton liver, the iron is in the form of ferric. But ferric form is not absorbed into our gut. So it will be reduced into the ferrous form. How to get reduced? Now, ferric form should be attached with hydrogen ion. Then it will be reduced into ferrous form. From where this hydrogen ion is coming, it will be coming from the HCl. So if there will be no HCl, there will be no hydrogen ion and no production of the ferrous ion. Clear? 5. You know, this HCl is very important for activation of the pepsin. Activation of the pepsin enzyme. And this pepsin enzyme is very important for digestion of the protein. So if there be no HCl, there is no active pepsin and no digestion of the protein. That means there is deficiency of the protein. There is deficiency of protein because protein gets digested only within the stomach in the presence of active pepsin, because pepsin is made from pepsinogen. Pepsinogen is the sleeping state of the pepsin, and from this sleeping state, hydrogen is the awakening factor and pepsin is formed from the pepsinogen, and this pepsin breaks down your protein into simple amino acids, and those simple amino acids will be absorbed into the liver. But if there be no HCl, there will be no digestion of the protein, there will be deficiency of the protein into your body. And you know, for clotting of the blood, one of the most important protein is fibrinogen. For clotting of the blood, one of the most important protein is fibrinogen. Fibrinogen. So fibrinogen deficiency will be there, and there will be chance of the bleeding into your body compartment. And if you add some blood thinner like clopidogrel, they can aggravate the chance of bleeding. So the clopidogrel and PPI, both, if they are giving to any patient, there is a much more tendency of the bleeding from that these two odd combination, because this combination should not be done. Now, second, prolonged use of the PPI, prolonged use of the PPI leads to the some gastric carcinoma, carcinoma or cancer. Another important thing, after a prolonged used, after a prolonged used, if you suddenly stop PPI, there will be much more acid reflux. So, after a prolonged use, if we suddenly stop, much more acid reflux, much more acid reflux, because gastrin is overactivating. Gastrin is overactivating. So when gastrin is overactivating, so normally much more acid production will be there and much more acid will be reflexed. So these are the major side effects of PPI. Now regarding the indication of the PPI. Regarding the indications of the PPI. That means where PPI should be used. Look here. The onset of action is almost a few minutes, but the steady state of the action are coming after 3 days of continuous supply of the PPI. That means suppose today I am taking one PPI, my acid is not controlled properly, then I am taking tomorrow another PPI, then I am taking on the third day another PPI. From the third day, the suppose first day, second day, third day, fourth day, so number of PPI. So I am taking, oh sorry, not number of PPI, that is day, that is volume of acid suppression. So first day, second day, third day, fourth day, fifth day, sixth day. That means first there is the linear, then the garbage, horizontal. That means after fourth day, the steady state of the acid suppression is there. That means there is no so much spiking of the acid or no further suppression of the acid. That means steady state. So steady state it will be achieved after 3 or 4 days. So don't get impatient. After one application or two application, you are expecting that much more acid suppression or continuous acid suppression. That is not possible. You have to use according to your doctor's schedule. So indication mainly hyper acid secretion, hyper acidity, gastroesophageal reflex disorder, because more acid will be backflowing into the esophagus and there will be lots of producing esophageal ulcer, esophagitis, etc. etc. Stomach, duodenal, esophageal ulcer, gastrointestinal bleeding, because in the acid medium the blood will be diluted. The blood will be more diluted. And some bacteria present into the stomach or gastrointestinal tract, this is for especially H. pylori, Helicobacter pylori, they are normally producing ammonia from this blood. And this ammonia is very, very dangerous. This ammonia is very dangerous. And this ammonia leads to the coma of your brain. Leads to the coma of your brain. Because the ammonia will be used to produce the urea in the liver, because ammonia is very toxic to the central nervous system. So if there be lots of ammonia is produced into the GIT system, they will be going to the brain, and there will be the cerebral shutdown, that is called encephalopathy, and the patient will go into coma and can be expired. So gastrointestinal bleeding, if you suppose there are lots of bleeding into the gastrointestinal tract, if you give proton pump inhibitor, it will not further dilute the blood, and it will also restrict the H pylori. It will also inhibit the H pylori. It will also inhibit the HCl. So blood will be clotted, and there will be lesser chance of the production of the ammonia, and those high ammonia will have not the chance to damage your brain. So in case of the active gastrointestinal bleeding, the brain damage will be lesser, and the blood clot will be formed here, and the chance of the bleeding will be lesser. Because suppose this is the damaged blood vessel and there is active bleeding, if there is some blood clot, the blood clot will be plugged and there will be no such active bleeding. So more acid, that means more active bleeding, less acid, more blood clot, so lesser chance of the active bleeding. Number 5, H. pylori infection, it can inhibit ulcer, not it can kill the bacteria, but it can limit the damage due to the ulcer. It can also be used to prevent the stress ulcer, because during stress lots of hydrochloric secretion will be there. So pre-operative, post-operative we can use. So lesser the volume of the HCl secretion. So these are the major indications of the PPI. Clear? These are the major indications of the PPI. Okay, so today's main topics is PPI. PPI basically proton pump inhibitor, because it inhibits the proton pump. Why it is called pump? Because it is energy dependent channel. In the presence of ATPase enzyme, the ATP is broken down into phosphate, and this phosphate provides the energy to this pump, and this pump releases the hydrogen ion. So proton pump inhibits this ATPase enzyme. Another thing, this proton pump inhibitor basically covalently combines with the cysteine molecule and inactivates the pump. So proton pump will not be functioning. So this PPI is very important drug. So if you want to join our institute, please call 62910 86211. Thank you. Good night.